Okay, good afternoon, and welcome to our webinar on fertility and pregnancy care during the COVID-19 pandemic. We hope all of our viewers are keeping safe and healthy. We know that these have been very challenging times for all of us, and we wanted to acknowledge that this has been particularly difficult for couples who are trying to conceive or are currently pregnant. We hope that this webinar provides you some valuable information to put your mind at ease and to help you make more informed decisions about your care. My name is Dr. Mira Shah, and I am a reproductive endocrine and infertility specialist at Nova IVF. I am joined by Dr. Robinson, who is an infectious disease specialist at Stanford University. Together, we will be covering a range of topics today, including a background on COVID, how it impacts the fertility community, and how reproductive health clinics, and specifically Nova IVF, are approaching resuming care for patients in a safe and responsible way. So for our viewers that are live with us today, we will try to leave some time at the end of our session for you to ask questions. Feel free to use the Q&A icon at the bottom or top of your screen, which will allow you to ask questions anonymously. The webinar will also be recorded and will be available at our website, novaivf.com, novaivf.com, and as well as Dr. Robinson's YouTube channel, which she'll tell you more about. And so without further ado, I'd like to give the virtual floor to Dr. Robinson, who will provide an introduction to COVID-19.
Great, thank you so much, Dr. Shah. Yes, as she mentioned, I am an infectious disease specialist and have really focused on emerging and re-emerging viruses such as COVID-19. And so I'm really happy to get to share with you some of the information that we're learning about this virus in real time. So as many of you know, the signs of symptoms of COVID-19 can be fairly similar to what we see with other viral infections and common colds. So a fever, dry cough, muscle aches and pains, as well as a sore throat and nasal congestion are all common symptoms of COVID infection. I'd also just like to mention that we are learning more and more about this virus, and there are some studies that show that there may be some impact. Great. Great. So I wanted just to mention that there are some studies that are showing that COVID can infect some of the cells that are in our gastrointestinal tract. And so diarrhea is also a symptom that may be associated with COVID. So I would just put people on a warning that that can also be a symptom of infection. Some studies have shown that there is also virus that's detectable in stool. So another question that we wanted to address is who is at risk for COVID? I just wanted to say that there's no specific population that is immune to COVID-19 infections. But what we do know is that this virus tends to infect our older patients and produce more severe disease in these patients. So those over 70 have been shown to have developed more severe disease and have higher risks of death when they're infected. We also know that those who have other chronic illnesses, such as lung and heart disease, also are at higher risk for severe infections. We're also learning a little bit more about the subtleties between the genders. Several studies have shown that men are more likely to be infected with COVID infections, with COVID virus, and that they are more likely to develop severe disease and have higher death rates. While we don't know exactly why this is true, we know that women tend to have more robust immune responses, which can predispose them to having a higher risk of autoimmune illnesses, but this may lead to them being able to clear the virus more quickly and prevent severe COVID infections. Another important point to make is that some studies have been associating COVID infections with stroke risks. So we know that the original SARS virus was also associated with stroke, And a recent New England Journal article coming out of New York identified 5 patients that developed strokes that were also positive for COVID-19. All of these patients were under the age of 50. And many of them did not have other risk factors for developing stroke. And so this brings to question some of the other severities that COVID infection may lead to. And some have suggested that this infection may lead to an increase in the clotting of our blood, as well as a dysfunction in the cells that line our blood vessels. And this may be leading to clotting dysfunctions in people who are infected with COVID. So I would just want to put a plug out there. I know that the younger people out there feel as though they're not at high risk for any issues related to COVID, but that we're really still learning a lot about this virus, and we all should be cautious.
Yes. And while the data is limited, we have no reason to have concern that COVID-19 impacts fertility directly. The virus does not appear to affect human gametes like eggs and sperm that we know of. It's also not sexually transmitted. The only study to date that has suggested a potential impact on male fertility was a study on severely ill older male patients who, upon autopsy, were found to have COVID-related orchitis, which is an infection of the testes, which can impact the local sperm environment. But this was a very small subset of patients. I think there were about 6 who were severely ill. So again, we don't believe that this is generalizable and that there should be major concern that this affects male or female fertility.
So next we wanted to discuss how COVID-19 specifically affects pregnancy. While most of the studies have not shown that there's an increased risk of infection or severity in pregnant women, I think it is important to note that in other viral infections, such as with influenza, pregnant women have been at higher risk for severe disease. So we really kind of want to keep our eye out on what the real effects of COVID are on this population. But we are really learning that many of these different viruses that are emerging have different abilities to affect humans. So another more recent emerging virus, such as Zika, was found to be able to infect the cells of the placenta and then pass from mother to fetus. However, we have not found, or the research community has not found, that COVID can infect those placental cells. And so we're still learning a bit more, but we know that in other situations we've seen increased severity in pregnant women, and we're still waiting to hear more information about this.
Mm-hmm. And so in terms of the recommendations or guidelines from the American College of OBGYN, or ACOG, they have not recommended against couples who are trying to naturally conceive during this time, as again, we don't believe that the virus disproportionately affects pregnant women. In regards to risks to the fetus, the CDC and ACOG both state clearly that it's just too early to know how COVID might have an effect. So with the limited data available, we don't believe that there's any associated risk of birth defects or other pregnancy complications, but we simply don't know the full scope of risks at this time. In the first trimester, there was a very small case series that indicated that there were no increased risks of miscarriage, so that was certainly reassuring. The only potential risk of COVID in the first trimester is the risk of a high fever, which in some studies has been correlated with the risk of birth defects and miscarriage. Some pregnant women with COVID-19 have had preterm births over the course of the last few months, but it's not clear whether the preterm births were because of the COVID or one of the other many possible etiologies of preterm birth. The bottom line here, though, is that we just don't have all the answers at this time, and so we're actively trying to collect data. And one initiative to do so is the ASPIRE trial, which is led by a group of physicians at UCSF, and they are collecting data on all IVF patients with COVID and tracking their pregnancy outcomes as well as their neonatal outcomes in a registry. So this data, of course, won't be available for at least 1 to 2 years. Until then, We just have to remain very cautious and take all the precautions to minimize risk of exposure for pregnant patients. In terms of breastfeeding, there really isn't any evidence that COVID-19 passes through the breast milk. However, given the risks of viral infection to the infant, if the mother potentially could be positive for COVID-19, the CDC does recommend separation of the mother and the baby. Because breastfeeding has so many great health benefits and is an important source of antibody production for the infant, if there is even a period of temporary separation, it's encouraged that women continue to express milk either through expression or breast pumps to continue providing breast milk to their baby. Now, in terms of birth plans, many women sort of envision a particular way of delivery and a birth plan that they had in mind. However, I really do encourage those of you who are pregnant or who will become pregnant to be flexible during these times because the guidelines are changing regularly. Talk to your OB/GYN about how you can preserve as many elements of your birth plan as possible. For example, if you had wished to have a doula present during your birth, many are offering virtual doula services during COVID-19 to help coach you and your partner during the early parts of labor. And finally, a quick note on home births. If you were planning a hospital birth, it's certainly not the time to make a last-minute decision to have a home birth just to minimize your risk of exposure. Home births have their own set of potential complications and require a certified home birth midwife, as well as access to a hospital if any complications were to arise. So if you are early in your pregnancy, certainly talk to your OB/GYN about the risks and benefits of these options so that you can make an informed decision.
So I think this is a really hot topic right now. Is do we have a good drug to treat this infection? And I think many of you may have read that there were some recent articles that were coming out about the efficacy of a drug called remdesivir. This drug inhibits the RNA polymerase of COVID-19, so it's not able to replicate as it would within the cell. And what this initial study showed is that there was a 31% reduction in the time to recovery between patients who were infected with COVID-19 and were treated with remdesivir versus those treated with placebo. They also found a trend towards an improved survival rate in those who were treated with remdesivir. So these were, of course, sicker patients, but there was a mortality rate or death rate of around 8% in those who were treated with remdesivir and 11.5% in those in the placebo group. So I think this is a promising drug. And we'll learn more about it. Remdesivir has been used in pregnant women previously to treat Ebola in the past, but I think an important thing when thinking about these drugs and specifics is also understanding the dosing necessary and if there will be side effects that may impact our pregnant population. The other promising drug that I think many of you have heard about is chloroquine. This is a drug that's been used to treat malaria and has been also used in pregnant women. We don't still know the exact mechanism of how chloroquine is affecting COVID, but the thought is that it's preventing the virus from entering in the cell and then trafficking throughout the cell to replicate itself. So these are two drugs that I think have some promise. They've also shown some potential synergistic effects. So the combination of remdesivir and chloroquine may be something that really improves outcomes. But until we have, I think, more data, a lot of what we're doing right now as far as social distancing and personal protective equipment are really going to be key to flattening the curve. Another important topic is the diagnostic tests that we are now using to identify those who are infected with COVID. And this allows us to isolate those who are acutely infected, as well as identify others who have been exposed to that infected person and have them also quarantined to prevent further spread. There are two major categories of diagnostic tests for COVID. One is called an RT-PCR test. And importantly, this is testing for viral RNA. So that's what it's looking for. And if you've ever had a test that was a swab, so either up the nose or in the back of the throat, that's what this is testing for. These RT-PCR tests are evaluating for active acute infections. But it is important to know that while if you are having symptoms of COVID and have a positive PCR test, that's very indicative of having an active infection. Later on down the course, these tests will also test positive if there is non-replicating or infectious virus. The other types of tests that are being used are called antibody tests. So these are the blood tests that have been developed. And these tests are measuring our human immune response to the virus. So once we're infected, our immune system starts to make antibodies to fight off the virus. And that's what these tests are measuring. However, the antibodies do not come up in the blood until later on into the course of infection. So these are really being used more to evaluate if someone has been exposed, or if someone has antibodies that may make them more immune to the infection in the future. And while these are very important tests, I think it is important to realize that some of these tests have had differing accuracy rates, and oftentimes these antibody tests may not be as specific as we would like. So the antibodies that we're testing, they may cross-react, which means you may have antibodies in your system that look to the test like COVID antibodies, but are actually antibodies to something else, so to a different virus that looks something similar. And that's a lot of the discussion that we've now been having about what is the percentage of people that have been exposed to COVID-19. But I would really think about these tests as complementary. So both of these tests give us different information and can give us a better view of what the status of a person is as far as their COVID-19 exposure. And I think really importantly, I wanted to also talk about how we can protect ourselves. I think this is something that we can proactively do to protect our own health as well as the health of our loved ones and our communities. COVID-19 has been shown to be transmitted through droplets, through our respiratory system, as well as through contact. COVID-19 droplets have been found to be larger in size, so greater than 5 to 10 micrometers. And that's important because droplets of that size tend not to remain in the air for a long period of time. They usually will drop out of the air. And so the surgical mask that we're using often will be sufficient for us to prevent infection, whereas the N95 masks are usually used for those who have those infections that have a smaller droplet size. However, either one of these masks will be helpful in preventing the infection of COVID-19 through the respiratory tract. And I would importantly remember that we should be thinking about all of our mucous membranes. So that's our eyes, our nose, and our mouth. And those are the routes that really COVID-19 can infect us. Also importantly, we can be infected with COVID-19 through contact with surfaces that have the virus. A recent New England Journal article looked at how long the virus can survive on different surfaces. They found that it can survive on copper for approximately 4 hours. It can importantly survive on cardboard, so all of those Amazon packages that we're getting, they can survive on cardboard for up to 24 hours, and on plastics and stainless steel for several days, so 2 to 3 days. So I want us all to really be thinking about being vigilant about cleaning our surfaces as well as cleaning our hands as frequently as possible, because as these surfaces may get reinfected, they can persist for a longer duration of time.
So I'd like to take a moment to mention where we stand globally and nationally today with the COVID-19 pandemic. So an excellent resource for daily updates is the Johns Hopkins Coronavirus Resource Center. And as of this morning, this is data from this morning, there were over 3.1 million cases worldwide and over 218,000 deaths. The US does lead with over 1 million confirmed cases, and 18 states that report more than 10,000 cases. New York has unfortunately taken the largest hit with over 17,000 deaths total. This compares to 1,700 deaths in California, of which 1,000 were in LA County. And how are we doing in Santa Clara County? Well, fortunately, due to a number of measures put in place earlier than other parts of the country, including, for example, many tech companies instituting shelter in place before the county mandate, we seem to be doing okay overall. This illustration down here represents new cases reported on a daily basis. Overall, we've had over 2,000 cases with 106 deaths. But as you can see here, in the last 2 weeks or so, we have seen some evidence of flattening the curve. So this is really a testament to all of you out there who are adhering to these county measures. So we really do thank you for your efforts, because we really do believe that they are making a difference, and we certainly know that it's not easy to make all these transitions in your life. So here's a timeline of where we've come since December, when the first case of COVID was learned of in Wuhan, China. Within a few weeks, the first reported cases were seen in the United States. And at the end of January, there was actually the first case documented in Santa Clara County. So as we really started to see things unfold, the Bay Area instituted the shelter-in-place measure on March 17th, which has now been extended until the end of May. And in response to this, both international and national medical organizations began issuing recommendations for how to respond to the COVID pandemic. And days before the American Society of Reproductive Medicine released their first statement, the European Society of Reproductive Medicine actually recommended that all fertility patients avoid becoming pregnant, and that all cycles be converted to freeze-all, and that an embryo transfer would be performed at a later date. And this was really based on the limited data that we had on pregnancy, as well as the unknown risks of these potential therapeutic interventions in pregnancy. So the ASRM, or the American Society of Reproductive Medicine, they convened a task force which comprised of a very multidisciplinary group of physicians, embryologists, epidemiologists, and infectious disease experts. They helped provide the first set of guidelines, which were released on March 17th. And as we'll go into a little bit more detail in the next slide, they essentially recommended halting all new treatment cycles. And this decision was largely based on the fact that, fertility treatments do require multiple visits in a short period of time. And early in the pandemic, the priority was really to minimize the community spread. And so they made the very difficult decision, in accordance with other national organizations such as the American College of Surgeons, to put a halt on all of these procedures and treatment cycles. Since the March 17th release, the ASRM has been committed to updating the recommendations every 2 weeks. And so since then, we have now received 3 new updates. So in the early stages of the COVID pandemic, the task force recommended implementing a moratorium on non-urgent care until we were really able to better assess the trajectory of the transmission rates and the healthcare system's ability to respond. And so these were the salient points from their document. The first recommendation was to suspend initiation of all new treatment cycles. So this included ovulation induction with medications like Clomid and Letrozole, IUI treatments, IVF, including egg retrievals and frozen embryo transfers. Second was the strong consideration to cancel all embryo transfer cycles. They did allow continuation of care for patients who were already in cycle or who required urgent stimulation. For example, cancer patients who are going to be undergoing chemotherapy in the near future. And they did also recommend suspending elective surgeries and procedures. Finally, they recommended minimizing in-person interactions and increasing the utilization of telehealth. And I will say that this has been one of the few silver linings during the pandemic. Telemedicine has allowed us to stay connected with our patients, and has actually also allowed us to increase access to patients who would have otherwise had difficulty accessing care. So again, the next two updates after the initial one remained pretty consistent with the initial guidelines. However, the most recent guidelines that were released last week, that was really the first set of guidelines that we saw real change, and we were all eagerly awaiting this. So the new update acknowledges that now we have enough data to really recognize that there are regional differences in the US, and we can really understand the trajectory of COVID-19 in these regions to be able to better assess whether it's safe to resume care in our region. So they recommended several milestones be met prior to resuming care. This included sustained reduction in the number of cases and the ability of local hospitals to safely treat all patients without having to resort to crisis standards of care. They strongly recommended clinics perform a formalized risk assessment to determine whether, which medical services were appropriate to resume and for which specific patients. So in regards to offering care to patients, they recommended resuming treatment for those in which delaying treatment might negatively impact their outcome. This would include our older patients over 35, those with diminished ovarian reserve, or prior poor ovarian response to stimulation. And importantly, they also really wanted to factor in mental health as an important factor in deciding for whom we should resume care. And in terms of how to safely resume care involved instituting policies and procedures to mitigate risk, ensuring adequate availability of personal protective equipment, and testing and documenting immunity, of course, once we have better tests available. So clinics across the country now are beginning to resume care, and I have to say that the camaraderie amongst all of us and the willingness to share our protocols and the resources has been really nice to see. Here are some ways in which our practice at NOVA is mitigating risks to patients and the staff and our community. All of these measures are in accordance with the CDC and the ASRM guidelines. So the first thing is that we're instituting a no waiting room policy to decrease transmission. We are performing a screening questionnaire for all patients prior to entering into our facility. We will inquire about travel, symptoms, potential exposures, and whether our patients have been practicing social distancing. Then every patient will have their temperature checked, and they will not be allowed inside the facility if they have a fever. The only exceptions we'll make to this is if it's for an urgent or emergent medical need. All staff and patients are required to wear masks. We are having longer appointment times to make sure that we have enough time to disinfect rooms and to minimize the number of patients in the office at any given time. We are requesting a no partner policy. However, we are making rare exceptions to this for certain types of procedures. As I mentioned, our cleaning protocols are in accordance with the CDC guidelines, and our staff, you will find, is split up into teams to, again, minimize additional exposure. And this is something we hope to implement hopefully in the weeks to come, but we hope to implement testing and documenting immunity for all patients that are beginning a new treatment cycle. And from our patients, we really do expect you all to maintain social distancing in your own personal lives, practice good hygiene, wear masks in public, and notify your office or us with any new onset of symptoms. The last thing I wanted to touch upon was women who are considering fertility preservation. Now, egg freezing is generally considered more elective than IVF treatment, which is considered more of an essential care. So one could really argue that these treatment cycles could potentially be postponed until a later date. However, some of the considerations for moving forward sooner with treatment would be the same ones that I mentioned earlier. Age over 35, low ovarian reserve, or conditions such as endometriosis, which are associated with a higher rate of future infertility. And any of these factors could potentially lead to a less optimal outcome in the event of a prolonged delay in treatment. So again, I suggest that you speak to your fertility doctor in your clinic to discuss your specific case and the optimal timing for resuming treatment. In general, if you have any reservations or concerns about starting treatment, you should really wait until you feel ready. And some considerations for delaying treatment and why you would consider that would be, for example, if you're a medical personnel in the front lines with very high exposure risk to COVID, or if you have any underlying medical conditions such as a respiratory disease that would make you more susceptible and would increase your risk of complications during our egg retrieval procedures, for which you do receive anesthesia. And so if you're wondering what you can do if you are waiting, I would really recommend that you practice more self-care. As much as you can, exercise, eating well, potentially talking to your doctor about starting supplements, which, as many of you know, take several months to have an effect on improving egg quality. But there are some things that you can do in this period of time that you're waiting so that you don't have to feel like it's as wasteful. All right, so we just would like to conclude the webinar at this point, and thank you all for your time. We really appreciate that you took the time out of your busy schedules to learn a little bit more about where we stand currently with COVID and how it relates to your fertility and pregnancy care. Dr. Robinson, I'll let you talk a little bit about your YouTube channel, which has some other excellent resources for learning more about the COVID virus.
Yes, thank you all so much for your time and attention. If you are interested in learning a little bit more about some of the up-to-date research that's being done on COVID-19 and how that affects your life, you can subscribe to a YouTube channel that I recently started called Our New Viral World, where we're discussing a lot of those issues and what the new research that we have discovered can really do to impact this virus. So thank you very much. I really appreciate all your time and attention. It's been a great opportunity to get to speak to you guys today.
And just a couple more resources. Resolve, or resolve.org, is an organization which supports couples going through infertility treatment. They have access to really great resources and support groups and have been particularly helpful during these challenging times. Our clinic is also sponsoring a webinar in collaboration with one of the fertility coaches, Pradeepa, entitled Finding the Calm, Your Calm in the Center of a Storm, and that's going to be on May 12th. So if you're interested, please email us at nova@novaivf.com. You can follow both of us on social media. And with that, I will open it up to questions from the audience. And we have received one question, so I'm just going to read through this quickly. Okay, so the question was about whether you should try to conceive naturally during this time, or is it smart to wait? Well, again, it kind of goes back to risks of COVID for you specifically. So I would say that if you are someone who has a high risk of exposure because you're a nurse or somebody on the front lines, then you potentially might want to consider delaying it, because again, as I mentioned before, it's too early to really know what the full scope of risks are for both you and the potential pregnancy. But I think that if you're healthy and your job allows you to take the precautions to maintain social distancing, and you feel like overall you're low risk and healthy, young and healthy, without any other underlying medical conditions, I do think that it's safe to try to conceive on your own. And as I mentioned earlier, the American College of Obstetrics and Gynecology has not put any restrictions on couples trying to conceive on their own. So it is sort of an answer that's specific to you and your specific medical history, but in general, we are telling patients that they can attempt to conceive on their own naturally.
And I would just chime in shortly and say, I think we're still really unsure how long some of this shelter-in-place requirements will be and how this will play out later on. Without a vaccine or a good treatment, we do believe that there could be a second wave of infection once people are able to go out and live more of a normal life. And so there may be several additional waves of COVID after this initial peak. And we still kind of don't know what that timeline is.
Great. Well, we don't have any other questions at this time, so hopefully that means that we did a pretty good job of answering your questions during the webinar. You are welcome to reach out to either of us if you have any questions that come up after the session. Again, this will be recorded. You're welcome to share it with your friends and colleagues. And again, thank you for your time today, and we hope you all stay safe and healthy.